pleased to invite Dr. Ngọc Ly Lan, our Principal Investigator at Gene Solutions. Please welcome Dr. Lan.
Good morning, doctors and distinguished guests. My name is Lan from the R&D team in Gene Solutions. And today I would like to share with you some perspectives regarding the new direction in genetic testing. That is the use of multi-layered data, including multi-omics and AI in precision oncology. And as you already know, the tumor is heterogeneous. It doesn't consist of just one cell type, but rather multiple clones with different genetic profiles. And the tumor is also not static. It changes over time, especially under the pressure of treatment. New clones arise with new resistance mutations, and that leads to a failure of therapy. And right now, the tools used in clinical practice includes imaging to visualize the structure and size and location of the tumor, and pathology for diagnosis to visualize cellular morphology as well as protein expression. Genetic testing is a newer tool, but it has gotten a bigger role in the past decade to identify DNA alterations or actionable biomarkers to guide targeted therapy. And talking about clinical biomarkers, this field has expanded very rapidly in the past 30 years. It started with immunohistochemistry, PCR, and now with the help of next generation sequencing, there are more and more biomarkers that are being approved every year. And it's not just about the number of biomarkers, the complexity of these biomarkers also increases. From point mutations like SNV and indel, now we have gene fusion and rearrangement, chromosome structure variants, as well as complex biomarkers that requires a large gene panel to determine like tumor mutational burden or TMB, microsatellite instability like MSI, and homologous recombination deficiency like HRD. And each cancer type has different list of biomarkers being approved, and there are even more in clinical trials and research. And not only that, the clinical utility of the biomarkers is also increasing, not just for diagnosis, or it has predictive value to guide treatment selection. These biomarkers can now help for risk stratification, prognosis, as well as monitoring treatment response. And with the expansion of biomarker landscape, genetic testing field has also evolved very rapidly, moving from simple genetic testing to a more comprehensive genomic profiling. So the more simple approach is using the FFPE DNA for single gene or hotspot or small gene panel testing, and mRNA is usually not tested. So the advantage of this approach is the lower cost and a fast turnaround time, but it has the risk of false negative result because it doesn't cover all of the biomarkers. And as a result, the patients may miss the treatment opportunity. And they can still do the sequential testing later on, but that will result in an overall higher cost, and there's a risk of tissue exhaustion. So with that, now we will see a trend to move from the single gene or small gene panel to comprehensive genomic profiling using large gene panel or whole exome sequencing or even whole genome sequencing. And this is to make sure that we can cover all of the biomarkers for diagnosis and as well as treatment, selection, and monitoring. And transcriptomic profiling or mRNA sequencing is also now slowly integrated in different genetic testing because mRNA sequencing has a higher sensitivity for detecting fusion variants. It can also provide gene expression profiles or able to detect very new and complex markers like tumor microenvironment or neoantigens. So with this comprehensive approach, there will be higher cost and longer turnaround time, but it will have the convenience that just one sample, one testing, and you have a comprehensive molecular insights to optimize a treatment plan for the patient. And this is our own data in lung cancer patients showing the benefits of combining both DNA and mRNA sequencing. So mRNA sequencing, as I mentioned, has a higher sensitivity to detect fusion variants, about 20% higher sensitivity compared to DNA sequencing. However, in real world FFPE samples, 35% of the samples have low RNA quality. So that prevents the routine use of mRNA sequencing to detect fusion in all of the FFPE samples. So for that, we combine both the mRNA and DNA sequencing together to maximize the sensitivity to detect fusion variants in lung cancer patients. So as you can see here, if we only do either DNA or only either or RNA alone, we will miss out a certain number of patients or samples positive for fusion variants. And so that is for the FFPE tissue profiling. And as we know, tissue has always been a gold standard for genetic testing because it has higher sensitivity because of high tumor content, but it only can provide a snapshot of the genetic profile in space and time. And as I mentioned earlier, the tissue or the tumor evolves during the course of treatment, and rebiopsy might not always be possible because it's an invasive procedure. So liquid biopsy is a very useful sample type that can address that gap, even though it has a lower sensitivity, but it is a minimally invasive collection of sample, and it allows for real-time monitoring of the tumor evolution. And the use of liquid biopsy profiling has two main applications. The first one is to profile all of the actionable biomarkers in the blood. And besides the tissue-derived mutations, the liquid biopsy profiling can capture tumor agnostic mutations, which are the mutations not present in the tumor. And this is the case when there is an evolution of resistant mutations after treatment, or the case when the tumor has a low DNA quality or there's sampling bias that affects the accuracy of tissue profiling. And then the liquid biopsy profiling will be a very good complementary tool to provide a complete picture of the mutation profile for the patient. And the second application is if the mutation profiling is sensitive enough with the lower LD below 0.1%, it can allow monitoring of MRD or minimal residual disease. And the presence of MRD or the ctDNA has been shown very robustly in the literature that a ctDNA positive can predict a recurrence, and the monitoring ctDNA can help to predict the treatment response as well across different cancer types. And this is our real data to illustrate the point that if we are using FFPE alone, across different cancer types, what we observe is that only about 80% of the FFPE samples that we receive from different countries in Southeast Asia achieve the high quality for next generation sequencing. And about 10 to 20% of the FFPE samples that we receive have low DNA quality. And about 5% of the FFPE had low tumor content, even though we request that the tumor content to be at least 20%. So because of that, if we combine FFPE and liquid biopsy profiling, the liquid biopsy profiling can help to identify extra additional actionable mutations. In this particular cohort, 11.5% more mutations compared to FFPE only profiling. And especially we can identify resistance mutations like EGFR T790M. So again, we believe that the pairing of FFPE and liquid biopsy profiling could help to maximize the detection of actionable mutations, and it can allow enable MRD monitoring if the liquid biopsy assay is sensitive enough. So when we talk about ctDNA MRD monitoring, it's not just about mutation. It's about to identify the signal of ctDNA in the blood, because a ctDNA positive or presence in the blood can indicate a higher risk for recurrence or disease progression. So because of that, we can a lot of the tests now move beyond just mutation detection, but rather integrate multiple features of ctDNA. And ctDNA is different from a normal, healthy, cell-free DNA, not just about mutations, but also for copy number alterations, methylation, or difference in fragment length distribution. So by combining both the mutation and non-mutation genome-wide features by using shallow whole genome sequencing, it increases the sensitivity to detect the presence of ctDNA in the blood. And in order to combine these features, we use machine learning models and in Gene Solutions, we have two different models for liquid biopsy, ctDNA MRD monitoring. The first one is to distinguish the ctDNA negative and versus the ctDNA positive blood samples of the cancer patient. And also the second model is to distinguish between a cancer-specific mutation and a CHIP mutation. The CHIP mutation is a somatic mutation in white blood cells, and you also will see it in the liquid biopsy. And we have shown in our paper that especially for tumor-naive testing, MRD testing, the addition of non-mutation features significantly increased the sensitivity to detect ctDNA compared to using mutation alone. So this multimodal ctDNA analysis is more sensitive than just using mutation. And so far that was about genomics. When we talk about ctDNA or DNA, RNA, DNA, so that's genomics. But you will see more and more studies with very complex design using multi-omics, including genomics, epigenomics, transcriptomics, or proteomics, and so on. And they use all of these different large data set from the tumor or from the liquid biopsy to provide a very large and complex picture of all the different molecular insights of the cancer or tumor. And beyond that, there are also studies combining the molecular information with imaging data from CT scan or MRI scan, as well as clinical information like health records, family history, or other blood test results. And with this a large amount of data, it requires multiple models, AI models for training. And ultimately, the output of these models are very complex, ranging from diagnosis, staging of cancer, to recurrence risk, or even toxicity probability. And the list is very long for all the potentials of these multi-omics and AI combination. And in Gene Solutions, one of the application that we've used so far is to use machine learning combined with our transcriptomic profiles of the FFPE, and we use our model as the ORICUP, using the top 2,000 most highly expressed gene in the tumor of the patients to predict the tissue of origin. And this is used for patients with cancer of unknown primary. And so far, we have shown that our performance to predict the tissue of origin for both primary tumors and metastatic tumors have been reliable and exceeded the performance of some of the existing model, like the CUP-AI DX model that is used in the literature. So even though with all of the promising data and result and outcome of multi-omics or multi-layered data and AI, there has also been concern about different aspects. For the first of all is the cost and the turnaround time. So with that amount of data, definitely there will be higher cost and very, very long turnaround time, especially if you talk about reimbursement or like insurance. But the also a very big challenge is the overwhelming large data and very complex technical information, and that might be very challenging to interpret the test results. And finally, one of the biggest concern is the limited clinical benefits for the patients, because despite a large amount of data, there are not yet enough drugs that can match with those biomarkers, especially the novel ones. And also there's also a lack of clinical guidelines for the physicians to know how to use this data to benefit the patient in the clinical practice. So in conclusion, I think we are entering a new era of precision oncology, where there will be cross-disciplinary, multimodal, multi-omics data analysis with the help of AI integration. There will be multiple sample types that can be used with multiple biomarkers, and multi-omics, and as we mentioned before, and even you can combine the molecular information with pathology and imaging and clinical information as well. But the question for you to think about is, are we ready for this data tsunami? I think this is a very nice illustration about the amount of data that we will have to face when we combine all of these data sets and with AI. So my personal view is, for research, I think yes, probably, but it requires very careful and thoughtful design, and make sure that we understand all the technical insights and the outcome of the research. For clinical practice, I think it will still be early for that, because when you have a patient in front of you to make decision for their therapy, I think the turnaround time and the cost is very important. So choosing a test with reasonable cost and turnaround time, but while still maximizing biomarkers, is the approach I think will be a more appropriate approach for clinical practice at this moment. Yes, so with that, thank you very much for your listening.